Good morning, everyone. My name is Nicole Varner. I'm Chief of Staff for Congressman Mark Vesey, representing Dallas and Fort Worth, Texas. As you can see, I am not Chris Cox, who represents Congresswoman Clark from New York. But I'm still happy to be here with you all today with these fantastic panelists, and we're going to have a fantastic discussion. First, I'd like to thank Dr. Gary Puckrin, President and CEO of the NMQF, and his team for hosting our Spring Braintrust and Summit on Health Disparities. And this is such a fitting theme for this year's summit, reimagining our healthcare to protect the most vulnerable. As we come to the end of the public health emergency that impacted our most vulnerable, we must acknowledge that now more than ever, access to care posed a threat to Americans before the pandemic, as well as during. Our communities face hurdles such as limited access to nutritious food, accessible transportation, environmental quality, and basic housing. This morning, we will discuss barriers to patient accessibility to necessary therapies. We'll dive into a more in-depth conversation around these barriers. However, we know that this conversation is rooted in health equity. As we begin, I'll allow the panelists to introduce themselves, and I'll start with Melody.
Hello, everyone. Thank you for having me today. My name is Melody Noreen Blackwell, and I am the president and founder of Color of Crohn's and Chronic Illness.
Hi, Jacqueline Roach. I lead payment and delivery reform and lead our Global Policy Institute at Johnson & Johnson. Thank you for having us.
I'm Sri Ramaswamy. Nice to meet all of you. I'm Vice President and Head of U.S. Commercial Communications at GSK.
Hi, everyone. My name is Ashira Vantries, and I am counsel at Aim Alliance, which is a nonprofit health policy organization.
Fantastic. Thanks, folks. And I'll ask the audience as well as my panelists to bear with me today as I literally am catching this Hail Mary for Chris. I didn't have much time to prepare. But we're going to start with the questions for the panelists now. I'm going to pick on you again, Melody.
It's all good. It's all good.
As founder and president of Color of Crohn's and Chronic Illness, you know all too well some of the hurdles our communities face. Would you lead us off to define what is health equity?
Absolutely. So my definition would be getting people what they need when they need it without putting them in poverty. But according to research, and these people who are much smarter than me, I'm going to go with the definition being that it means providing people with the opportunity to achieve best possible state of health, including giving them access to the tools that they need to manage that without causing financial detriment. Simply enough, right? Getting people what they need. But there are ranges and obstacles to this, and that limits the access to the actual healthcare that prevent people from effectively managing their health and their needs. Some of these limitations include education disparities, racial discrimination, ethnic discrimination, income gaps, lack of housing, and unsafe environment.
Thank you. Turning to Shri, you're the vice president and head of commercial communications at GSK. Mm-hmm. The company has a purpose to unite science, technology, and talent to get ahead of disease altogether. How does GSK execute this purpose through a health equity lens?
Thank you for having me, and good morning again to all of you here. As you mentioned, GSK has a very, very specific purpose, and that purpose is to unite science, technology, and talent to get ahead of disease together. Those are very important words and very deliberate words. But because when we talk about getting ahead of disease together, we're not just talking about preventing disease, which is, of course, really important. It's about making sure that all of us in this room are actually getting ahead together as a community, as people, as humanity. Dr. King once said, "I can never be what I want to be until you are what you ought to be." And so when we look at ahead together, we're looking at it in terms of healthcare for everyone. Importantly, good healthcare for everyone. Now, when we look at getting ahead of disease together, we're pioneering generational change. That's important in health equity. It's generational change in health equity because we're not just saying, let's do something today and stop tomorrow. We're talking about the momentum, the future. It's not just about a one-off event here or there. It's about a continuous momentum of touch points that lead to a better and brighter outcome for people. And also, we are looking at eliminating disparities in care for everyone, the underserved. The underserved includes people of color, but it also includes others who might be socioeconomically not in the right place. So it's a very broad definition, and we're very proud to stand behind it, and we're doing a lot, and we'll talk about that as we go through this discussion.
Absolutely. And, you know, we've kind of talked about it now from the health policy lens or the health lens, but Ashira, for you, from the legal perspective, what barriers does AIMED Alliance see for patients in ensuring health equity?
Yeah, so I think a really big barrier that we often encounter is a lack of proper enforcement of state and federal protections that place limitations on really burdensome benefit utilization policies. And I think what we need to understand is that enforcing these laws and protection is a health equity issue, because we know there are disparities often in claim denials. So there's a really important, I think, report from the Institute for Patient Access that was released at the end of last year that found within the kidney disease space, Black and Hispanic patients were 40% more likely than white patients with kidney disease to receive a claim denial. So obviously, when you're subject to that first claim denial, then you have to go through the entire appeals process if you know about it, right? And so I think that's a big barrier to people not knowing their rights. So that's a lot of the work that we do at AIMED Alliance is working in education and ensuring that when state and federal agencies are notified of these violations of the law and patient protections, they take robust enforcement action.
Absolutely. And so, you know, I'm a Capitol Hill staffer, and we look at everything through a policy lens. That's just how we're made. So turning to Jackie to dive deeper into the policy world, I understand that addressing barriers to therapy requires wraparound investments in community efforts, research, and practice, but much of it does start with policy. Can you share some of the key policy barriers that are currently causing patients unnecessary burdens in receiving treatment?
Sure. Thanks for the question. And I may step back for a moment just to ground folks in where we are thinking about some of these issues at J&J. So at Johnson & Johnson, we do strongly believe that health, economic, and social justice are at the core of a healthy society. And therefore, we strongly believe that the promotion of justice in healthcare will require both targeted and system-wide structural reform, both within and certainly beyond healthcare. And that's us really starting to think authentically in terms of where the private sector and the world's largest healthcare company can really pursue structural reforms in health equity that are deliberate and meaningful. So within that framing, we have engaged in an initiative referred to as our Race to Health Equity, where we've dedicated approximately $100 million over the course of 5 years to thinking about how we can partner to build and strengthen communities, enduring alliances, and make deliberate and meaningful commitments to our own diversity and inclusion within our own workforce. So I say all this just to suggest that I'm also, and J&J is a stalwart believer of the importance of the social safety net in a healthy society, but also in terms of having policies that establish the social safety net as the framework by which all things can rise and by which we can achieve these goals towards a collective social justice. And we're not going to be able to achieve that progress we need to assuring not only the protecting and strengthening of the social safety net, but making sure that we are establishing new and novel policies, innovative financing, et cetera, that will promote the ability for this social net to thrive. And we cannot do that without really thinking through what private-public partnership will look like. And where and I'm hopeful others are joining us, is I am reinvigorated or invigorated by this discussion on health equity this time around. I'm hoping that the interests of the private sector, the openness of the public sector sort of come together will be an important stepping stone in developing lasting policy change. I am a policy wonk, but I did spend many, many years working in Medicaid. I was a clinician in East and West Side of Baltimore. I've seen and done it all. But at the end of the day, if we don't get the financial incentives right within the system, we're going to really struggle. And so to answer your question more directly, in terms of the barriers, it's unfortunate. We're sitting at this precipice of all of these gains particularly gains in insurance, via the Affordable Care Act. 10 million folks. Certainly the ACA really proved its worth during COVID when we had millions and millions of people entering a system where otherwise they wouldn't have had a place to go. And we always, when I worked at the Obama administration, our goal there was, we know we're throwing some good money after bad, but we've got to bring people into the system first, get folks insurance and insured, and then we will address some of these other ills. The struggle there is getting to those other ills. And so in order to do that, we need to address both the social components, the economic components, and we need to pay for that. And we need to figure out a way to get those resources in. And so in terms of the barriers that folks are facing today, I really loved the quote by the prior panelist. I think it was Stephanie. And Stephanie, I'm going to be cribbing this for you, probably, hopefully always with attribution, but really we need to, instead of value assessing what we do value in our system is really critical. Yeah. And right now we have, on the precipice of wonderful innovation, precipice of much higher rates of insured folks, but now are entering all these new barriers to care that weren't part of the complicated U.S. healthcare system supply chain previously. So whether or not that's a significant, proliferation of PBMs and the role they play, guess what? We have a new acronym, Alternative Funding Programs. You can help me at the end of the table here. Very unclear what these folks are doing in terms of, other than extracting value for the system and creating new and fresh barriers for people who particularly need specialty medicines.
Right. And and not to interrupt, but
please.
A lot of the things that came out of the flexibilities that were created by the PHE kind of spoke to a lot of the things that you're discussing now, right? We had more flexibility with Medicaid programs. We had more flexibility with even just covering payments for vaccines. And so, with the barriers that we do face, the question kind of arises, how do we now, with having seen that, push forward? And I think Melody can talk a little bit about the barriers and how her organization is helping folks overcome those.
It's interesting because people aren't equipped to understand that they're actually in the midst of a barrier. They're just going along to actually get along. And that was actually my story. Coachy was birthed out of the fact that it took me almost 30 years to be properly diagnosed. And they normally say, well, you didn't have insurance, you didn't have access, you're not educated. I check all those marks. And I'm from Washington, D.C. In fact, I was born at Howard University Hospital. So I think I had access. I know I had health insurance. I did all my preventative care. And even at 13 years old, a little girl who was managing rectal bleeding still was told that she just had a hemorrhoid and navigated stomach aches and debilitating illness for over 30 years. It wasn't until I had hair loss, extreme fatigue, urgency, 8 fistula, drains in my colon, chronic eye infections, mouth ulcers, arthritis, and I lost my mobility for 3 months before I was properly diagnosed with Crohn's disease. Talk about fun time, right? And it's those challenges that when I was diagnosed with such severe and detrimental illness, while my husband and my family members and my child watched this and cheered his mom on to slide up and down the steps, did I get subjected to step therapy. I was given a course of pills. And when I asked my physician, will this work for fistulas? I'm in the hospital constantly. It should. And I trusted that doctor would direct me in the right way. But who was going to educate the person who's educated? Because health literacy is a whole nother lexicon that we are often dismissed from even being invited to understand or navigate with our provider. And if you know me, if I have lemons, I'm going to make some purple lemonade over here. So that's what I did with Coachy. I shared my story and my husband said, why are you sharing all this? I said, I don't know. But I know that when there is challenge, there's purpose. And when there's purpose, there's progress. And I'm supposed to share this with someone. And when I shared, I was led to over 100 people. And people were telling me they were the first Black person or the only Black person diagnosed with this very debilitating illness. And I said, why would they think that? And I realized why. And I said, they have no idea what they're going through. Once I got deeper into this space of health policy and health equity, I learned that I had been subjected to step therapy. And finally, today on my 16th medication, from oral to rectal to injection to IV, I'm finally feeling well. But why did that have to be my story? I didn't suffer enough for 30 years. But that's what happens. And when you don't know that you're fighting against these policies and these inequities, you don't fight, and you respect that the person, the provider, is going to navigate you into the best direction that you can possibly achieve. And that's not true. So at Coachy, what we do is we educate, but we educate in a way that speaks to the communities that we serve, not in a space that's overarching or unattainable, but we swag and surf with you. We pop, lock, and drop if we need to do that. We show up to your schools. We show up to your classes, because community is a health conversation. That's a space where we do things together. Had I, with a fashion degree, this is not where I thought I'd be today. But we do tackle non-medical switching and step therapy and copay accumulators and understanding what it means to have to go through prior authorization when you're at your wit's end.
Yeah. And I think, it's really important to talk about these barriers from the patient side, not to put anybody on the spot, but Shri, how is GSK thinking about patient access?
A great question. First of all, I think we all need to give a big hand of applause to Melody for that very, very compelling testimonial there. And I think to her point about the community and about education, I think that's really important. The way I think about this, and we think about this to your question, is there are sort of three prongs to it. One is access. The second is affordability. And the third is prevention. And when we talk about access, how do you access something when you're not informed? You don't have the requisite knowledge to ask the right question. Give you a good example. In the African American community, endometrial cancer is a big deal. And what we did at GSK is we actually had a doctor speak to a patient who had symptoms of it and was suffering from it. And we took all these videos of the conversations that ensued between the doctor and the patient, and we built a website, and we housed this information on the website, and then we pushed it out through Divine Nine as well to their groups to educate people about about endometrial cancer, the symptoms, the signs, etc. So that's one example of education. We've done a lot of education also around vaccines. Not just in the African American community, but also in the Hispanic community. And what I can tell you is some years ago, quite recently, we actually teamed up with IQVIA, and we came up with something called Vaccine Track. And what that does is it actually tracks communities around the country where vaccination rates might be low. So what do? We go to those communities and we talk to people and educate them about vaccinations, for example. You may have seen this on the Today Show recently. We actually now have Magic Johnson, who's educating people about respiratory syncytial virus, or RSV, as many of you know it. And he's talking about sidelining RSV. And believe it or not, in this country, 170,000 people a year 65 and over are diagnosed with RSV, and there are 14,000 deaths a year from RSV. So what Magic talks about, and he says specifically about communities of color, is, if you've got a symptom, or just in general, even if you don't, get checked for these things, because it's important to get ahead of it. And so the education component also, COPD, asthma, these are also very big sort of diseases in the underserved communities of color, et cetera. So we're doing a lot of education in those communities. We're also, for example, doing work in ovarian cancer. During the pandemic, that a lot of women with ovarian cancer watched and waited. Mm-hmm. And watching and waiting when you have cancer is not the solution. So how do we do more in terms of encouraging people to screen, for example, to ensure that they are catching these diseases on time with their doctors? I can also tell you, in terms of education, if you talk about clinical trials, right? You may have seen recently, we actually published data. We went back 17 years. We did a retrospective study on clinical trials. And what we did is we were about 495 GSK trials with about 100,000 participants. And we compared that to the census data. to just see that perhaps it's a better indicator of the communities that you want to address and serve. So that's the education part in terms of action. In terms of affordability, just very quickly, in terms of affordability, we have, for example, programs in place like patient assistance programs, et cetera, right? But the important thing there too is you all know about the Inflation Reduction Act and the fact that part of it in terms of immunizations for seniors is now that the co-pays are being eliminated, which means that it takes out the barrier to cost in certain cases. And when we talk about, prevention, again, with vaccinations, for example, we know that during the pandemic, many people didn't take the CDC recommended vaccine because we couldn't, or there were barriers to it. So we're addressing all of those things. And I frankly feel very proud that we're working with the communities, working with hospitals, working with HBCUs, et cetera, to address it.
I'm going to come back to that
Yes.
HBCU part.
Sure.
But I wanted to turn to Melody again. You've shared some of your experience with access to necessary treatments. But can you talk a little bit about how we can get underserved communities the support that they need to navigate the challenges and the barriers to access?
I love that Sri mentioned HBCUs because we are on an HBCU tour. But I'll tell you, when I hear that question of how do we get underserved communities to navigate these challenges, I wrestle with that not because I don't have an answer, but let's be honest, while I, Melody, want to serve these communities and I want to provide them with help, I also understand that Kochi wants something from them. And we often disregard that space of the fact that we want something from them. We want to understand, we want insight, and we want data. And we need that information to prove that the communities actually need help. So we're trying to give them something, but also get. What they hear first is, what are you trying to get from me? They don't buy in to these normal deliveries or these high arching opportunities like a website, for example. They're not going and looking for this because a lot of times we don't know to navigate and look for it. When I think of support focused, I think it's more of a question that's probably saying, how do we invest in these communities and who do we invest in to do the work? Because we have to understand that the funder is not often the mobilizer. It's a community, it's an organization, it's a trusted space. It's the church, it's the community center, it's the people that look like those, because health equity is actually vulnerable work. We're being vulnerable. We're showing that we're human, and more than not, we want someone to come to us with a story. Because if you haven't lived through something that's challenging, you can't possibly know what it's like. You can't possibly know what I'm living through. And what I'll say is, I don't need you to feel sorry for me. I don't need you to pity me. So what Kochi's approach is to go in the community and be the community, because we are the community. Mm-hmm. We weren't birthed from a space that had a lot of endowments and funds to be able to say, we want to help you, poor person. We said, wow, this is what we went through. Did you know about this? Did you know that this is a barrier? Did you know that this is a challenge? Because now that offers people the ability to commune with you, have dinner with you, dance with you. And that's culture. That's real lived experience. And that's what people are looking for in these programs. They're not looking for you to stop by, get what you want to get from us, drop off some care packages and roll out. Mm-hmm. They don't want it. Mm-mm. And they're smart enough and wise enough to know that's what's going on. Mm-hmm. We have to remove the gimmick and figure out what it is to move things forward. That's what equity is. And you have to put the people in that want to be about people, not people that are coming to serve.
successful as you are, at least I'm honest about who I am and what I want.
Yeah.
Panelists, she had a kind of more broad question for you as a whole. Would any of the other of you like to, and you may need to just.
Yeah, I can repeat the question. Get my notes here. If how can pharma and biotech companies sort of rebuild that trust through admitting where they have failed, talking about that they've not been representative in the past rather than just, yes, focusing on the positives, great, but as an industry, we've messed up in a lot of ways. So openly talking about, where we've messed up.
I think trust and belief are often used interchangeably. That's probably the problem, because I believe this gentleman who's sitting in front of me has a tan blazer because he's wearing it. but do I trust that he might have a red one? You know, I think that it's important to be transparent in any space. And in order for people to even grow or increase trust, is you have to do things that are trustworthy. And being honest is trustworthy. When we go to our physicians and they don't know an answer, we are okay with them saying, you know, I need to do a little more research. I'll get back to you, as opposed to giving you a medicine that's going to put you in deeper peril. You know, that's important. So I would strongly say, yes, it's important to share the wins and the losses, the wins and the failures, because it allows people to say they're willing to show their hand, as opposed to showing that there's only 3 fingers up, but what happened to the other 2? They're very important.
I would just underscore the same in terms of speaking directly from a biopharmaceutical company, that you need to share your wins and losses, and then you need to own those losses authentically in a way in which all parties learn. So thanks for the question. A good one.
Remember that accountability isn't always bad, right? Like, it's important for us to learn from where we have made mistakes, and it can be beneficial in the future. And so we don't need to always look at it as a negative. We can say, okay, we've made mistakes here and we need to change going forward. And how do we change? And use that as the way we start a conversation. I know from working at Aimed Alliance and how we've really done work internally about figuring out how we can ensure our materials are more accessible. When I first started there, we do a lot of know your rights materials, education on what protections are available under the law. And we only had those in English. I'm from South Florida, so everything is in at least 2 languages. Yeah. And so that was the very first thing that I said when I started. I said, we need to have these at least in Spanish at a minimum. And I don't feel uncomfortable talking about that. We made that oversight in the past because I want others to check their own materials and do the same. And so I think we can have the same ask for our industry partners.
Thank you. And thank you for the question. Are there any other questions in the audience? I hope so. Don't be shy. I know it's early. I had my coffee though, and I see there's a coffee station out there. So, and I know there are a lot of curious minds, and it's like, don't make me beg for questions, y'all. All right. Gonna start bullying people soon. Bullying is bad. Sorry.
Good morning, everybody. Tamara McCants. I'm a pharmacist and a clinical assistant professor at Howard University. I have a question about PBMs, prior authorizations, because and your role, or all of our collective role in ensuring that people have access to medications when they get to the pharmacy. So what are we doing about PBMs? And what can we do? Are we even talking about it? Does everybody even know what a PBM is, pharmacy benefit manager? How can we ensure that people are getting the medications that they need when they go to the pharmacy?
Well,
You want to start and I'll go after you?
okay, good.
Oh, okay. I mean, that's a big question. There's a lot. I don't know if there's one answer. I do think a huge way we can identify how we can ensure people are getting access to treatments is transparency around PBMs, exactly how they work. I remember when I first started at AIMD, I was like, wait, I didn't even know this actor was in the healthcare space, right? And so I think there's great work done at Congress around PBM transparency, and really supporting that, I think, is a really important and essential first step to fully understanding the barriers that impair access to those medically necessary treatments.
I think I would just add that there's the education component to the person disappeared to the point in terms of what the PBMs are, what role they're playing, and how they intersect with the patient is really concerning. And then to my earlier plea about reforms out of Congress is really looking under the hood and determining what the fee-based structure is here and how that is or isn't helping patients. I think I know the answer to that hypothesis. And then I'll add that for the pharmacists who are trying to navigate all these different systems at the point of sale, the fact that there are these new players, the alternative funding programs, which are also specifically siphoning off specialty medicine, is particularly concerning. So I do think we need the state activity, we need the federal activity, and then we need, most importantly, the advocacy for many of the folks in the room now to really understand what these programs are, so that not only can we look underneath the hood, but then we can do the hard work of reforming on behalf of the patients. It's a great question. Thank you for asking.
So I just want to add a patient's perspective. You do know that PBMs have like turned patients upside down, right? We literally want to take the prescription, go to the pharmacy, get the medicine. So when you're a patient like me who has to deal with specialty pharmacy because my medications have to be shipped because of injections or going into actual center, it makes it so much more confusing. We have over 700 community members. And until we started to share what PBMs were versus retail pharmacy or specialty pharmacy, like we had to start educating them on that because they had no idea. They were like, oh, that's who that's coming from. That's why I'm getting a call from, I'm not going to name any name. And I said, yes, that's what that means. That's why you can't go to Wegmans or CVS at the counter. You can't go to Target. You have to do it this way because, and I think that there's a huge gap in bringing patients to the fold because when they give these prescriptions, no one's saying here are the next steps. If they're not connected to an organization or a community of some sort, they're just blowing in the wind until they meet this hurdle. And now there's a challenge. But I called my local pharmacy and they said that they're not filling my prescriptions anymore, but they filled my prednisone. They filled my this, but now I have to go here. So it's just, it adds another dimension that creates a spiral for people that are trying to tackle barriers. Yes.
Thank
I agree.
you. We have one more question.
I'm Lindsay Half with Exact Sciences, and I know you touched on the importance of prevention and screening. So I would love to get your take on the recent Braidwood-Becerra case and, you know, the fact that it threatens the ACA's preventative services and what your advice would be to those of us in the room who want to protect those benefits, especially for vulnerable patients.
Like that?
Yeah.
Okay. Yeah, thank you for that question. Very concerning. And prior to my time at J&J, I spent 10 years working on the implementation of the Affordable Care Act. And a number of the provisions, particularly ones around preventative care, were designed not only to provide cost-free access to care, but also the predictability and the benefits that come with knowing that a wide variety of screening is offered. So this is a real threat in an advocacy court with one person that really undermines access to millions of Americans to true preventative-based service, and whether or not that's colorectal screening or breast cancer screening or peripheral artery disease, many of the conditions that are incredibly important to the populations we represent here in the room. So it's going to take all of us to make sure that we attack this head on. I'm sure Congress is taking a close look at the activity in the courts, but it is in the courts. That does mean we're otherwise limited at the department and to some extent within Congress. So we really need to bring out the pots and the pans and start banging on drums about this, because this is a very, very dangerous precedent, particularly for folks that are falling through the cracks otherwise in terms of the plans and the types of health insurance that the ACA was designed to protect. I'm very concerned about this. And it's made worse by the fact that it's another area that's very complicated in the U.S. healthcare system, because you have to understand the nexus between preventative services, Medicare, Medicaid, ACA. Are you an expanded state? How are you covered? And it's not doing any of our beneficiaries and patients favors.
Yeah.
The crap policy.
Having been a health policy staffer for a member from Texas with no Medicaid expansion.
You got to take that on.
So these are the problems that we wrestle with every day. And thank you for the question. I'd like to thank the panelists for being here, and I'd like to thank you all for listening. Oh, wait, we're not done yet. I just would like to give the panelists a few minutes each to give their last words, and I'll start with Ashira.
Okay. Well, thank you all for coming this morning and listening to us, whether you had your coffee or not. We appreciate the questions. I think from today's discussion, we talked a lot about what we're doing to ensure that the future of our healthcare is more equitable. But I want to remind everyone that we still have a lot of power to take action right now. So through, sending that letter to CMS or HHS, or if it's about preventative care services, talking with employers, and really ensuring that people are educated on the benefits of really comprehensive health insurance. And I think, sharing our stories is so important. So if you have a story to share, use social media. Say how these laws are impacting you. As a pharmacist, what are you seeing for your patients? Our voices are powerful. Collectively, we're even more powerful. So I know we have a lot of work to do, but please don't feel that we can't do anything right now.
I just wanted to add to that and say that we're at a very interesting time, an inflection point in terms of healthcare, and the fact that we're actually having a social conversation about this. A lot more needs to be done. I think from training in medical schools to education, digital health, policy, and also just making sure that we bring everybody along so that when we look back at this decade, at this era, we actually can say that we were able to move the needle to provide equal access and good healthcare for all.
Sure. Thanks for having us. I think I would just underscore that we are at the precipice of a really compelling time. The ACA brought us unprecedented levels of insurance coverage. We have a fantastic number of life-saving innovations coming to market against these headwinds. But we would be so terribly disappointed if we left this zeitgeist on health equity without some tools in which to make sustainable and lasting change. So I would love to see collective partnership to think about those policies that are needed to create sustaining funding models for both social and health service care, and whether or not that's additional appropriations for Congress to pay for some of those social determinants, or more innovative payment models. We've got to get there if we want to keep this drumbeat going for the next generation.
Today is my organization's first Hill Day. So I want you to keep our advocates. There's about 20 of them out there to meet their legislators. So I want you to keep them in your minds, giving them well wishes and positive thoughts as they go and meet with their legislators to make positive impacts on the things that affect our lives.
Fantastic. Thank you all for being here today. And thank you, audience, for being here today and bearing with me in my last minute substitution. I hope you have a great rest of the conference. If you are making your way to the Hill today, feel free to stop by and say hello. Congressman B's office, Rayburn 2348. And with that, you can clap now.